Hello everyone. Let's get started. Today we are diving into chapter 1 which focuses on internal nutrition support. We will explore the delivery of specialized nutrition support, specifically using feeding tube or intravenous infusion, which is a critical intervention to help patients regain their health when they cannot eat normally. So before we delve into the details, let's look at our roadmap for today. Our first for the learning objectives for the part 1 in this chapter to identify the different types of oral supplements that patients can consume to improve their energy and nutrient intakes. So our first set of the objectives include identifying the different types of oral supplements patients can consume to improve energy and nutrient intakes. The learning objective 2 and 3, we will also learn how to identify patients who may benefit from tube feedings and describe the main feeding routes used in medical care. So, the learning objectives number 4 and 5, also we will describe the features of various enteral formulas and the factors that influence which formula we select for a patient. So, nutrition in the clinical setting. Let's begin by understanding why we need these interventions in clinical settings. Patients in hospitals are often simply too sick to consume a regular diet. Various illnesses can interfere with the food consumption, digestion, or absorption to such a degree that oral intakes alone cannot supply the necessary nutrients. In such cases, specialized nutrition support, which involves delivering nutrient using a feeding tube or intravenous infusion, becomes necessary to meet the patient's nutritional needs. Enteral nutrition versus parenteral nutrition. When we talk about nutrition support, we generally divide into two main categories. Enteral nutrition refers the provision of nutrients using gastrointestinal or GI tract, most often through tube feedings that deliver nutrient dense formulas directly to the stomach or directly to small intestine. On the other hand, parenteral nutrition provides nutrients intravenously and is reserved for patients who do not have adequate GI function to handle enteral feeding. It is crucial to remember that if the GI tract remains functional, enteral nutrition is always preferred because it is associated with fewer infectious complications and it is significantly less expensive. Now, let's look at the simplest form of intervention, the oral supplements. If a patient GI function is normal, but a poor appetite is the primary problem, we can often improve their diet using oral supplements, as known as oral nutrition support. Patients who are weak or debilitated may find drinking these supplements much easier than consuming full meals. A major benefits here is that a patient who improve their nutrition status this way can avoid the stress, avoid the complications and expense associated with the tube feeding. So, what do these supplements look like? Hospitals usually stock a variety of products, including nutrient dense formulas, milkshakes, fruits, drinks, and snacks bars for patients at risk of malnutrition. You will also see similar products sold in pharmacies and grocery stores for home use, but this is not available or not popular in the local market. Popular examples include liquid supplements like Ensure, like Boost, and Carnation Breakfast Essential. These products are highly reliable sources of nutrients that add necessary energy and protein to the patient's diets. Taste and acceptance. However, simply providing the supplements isn't enough. The patient actually has to drink it. When a patient uses an oral supplements, taste becomes a very important consideration. We must allow patients to sample different products and select the ones they prefer, which greatly helps promote the acceptance. Even when a person enjoys a supplement initially, the taste can become monotonous over time. Therefore, we should aim to provide only the products that the patient actually enjoys. How can we further encourage patients to consume these supplements? Serving supplements attractively, such as offering a liquid formula in a glass on an attractive plate, like here in the picture, is much more appealing than handling them a can with an unfamiliar name. Temperature is also a key. Keeping a liquid supplement in an ice bath makes it cool and refreshing, though you must check with the patient to ensure a colder temperature is suitable. If the smell is unappealing, try covering the glass with a lid or plastic wrap, leaving just enough room for a straw. Also, here is a few more logistical strategies. For patients with very little appetite, it's best to offer the drink or snack in small, easy to tolerate amount and severe it more frequently throughout the day. Access is also critical. Keep the supplement close to the bed and within sight of the patient remembers to consume it. If they tire of the product, suggest an alternative, which is why it's important to maintain an updated list of available supplements at your institution or the hospital or the clinic. Tube feeding in the medical care. When oral supplements are not enough, we turn to tube feeding. Tube feeding deliver nutrient dense liquid formulas directly into the GIT or gastrointestinal tract. They are recommended for patients who have a functional GIT but cannot meet their nutritional needs regular foods alone with the regular foods alone. While they are often the sole means of nourishment, they can also be used to simply supplement a diet when oral intakes is inadequate. Typically, these are patients at risk of developing protein energy malnutrition. Let's look at this specific condition that warrant this intervention. Candidate for tube feeding. Candidate for tube feeding include those with severe swallowing disorder, impaired motility in the upper GIT, or GI obstruction and fistulas that a feeding tube can bypass. Other indications include certain intestinal surgeries, prolonged periods of little to no appetite, specifically, especially in malnourished patients, extremely high nutrient requirements, mechanical ventilation, or mental incapacitation due to confusion, neurological disorder, or coma. Conversely, when is tube feeding absolutely inappropriate? Now, the contraindications include severe GI bleeding, high output fistula, intractable vomiting or diarrhea, and severe malabsorption. Additionally, the procedure may be contraindicated based on the time frames. We generally don't place a tube if the expected need of for nutrition support is less than 5 to 7 days in a malnourished patient or less than 7 to 9 days in an adequately nourished patient. Once we described uh, uh, once we decide a patient need a tube feeding, how do we deliver it? Now, the route we choose depend heavily on the patient's medical conditions, the expected duration on the tube feeding, and the potential complication associated with a particular route. The main route fall into two broad categories: transnasal placement, which go through a nose, and enterostomies, which go directly through abdominal wall. So these are the two routes. Transnasal feeding routes. Let's start with short-term access. Transnasal access is generally preferred when the tube feeding duration is expected to less than 4 weeks, about 1 month or less than 1 month. The patients the patient is frequently awake during placement and can swallow water to ease the tube's passage. The tube is inserted into nostril and passed into the stomach for nasogastric tube, or duodenum for nasoduodenal route, or jejunum for nasojejunal routes. We always verify the final position for the tip with an X-ray or other means. For infants or long-term need, we use different approaches. In infant, orgogastric placement, passing the tube into the stomach via the mouth, is sometimes preferred to allow the infant to breathe more normally during feeding. For long term access, longer than 4 weeks, or if the nasal route is obstructed, we create an enterostomy. This is an opening in the abdominal wall leading directly to the stomach, called gastrostomy, or the jejunum, called jejunostomy. These are created by surgical incision or needle puncture. Gastric versus intestinal feeding. Why might we choose the stomach over the intestine or vice versa? Whenever possible, gastric feeding like nasogastric and gastrostomy routes are preferred. They are more easily tolerated and less complicated to deliver because the stomach controls the rate which nutrient enter the intestine. However, gastric feedings are not possible if the patient have gastric obstruction, if the patient have motility disorders that impair emptying, or if the patient have inadequate stomach volume from prior surgeries. In those cases, in those patients, we bypass the stomach and use intestinal feeding. The aspiration risk. This is the major factor in route selection. Aspiration is a common complication where substances from the gastrointestinal tract, are drawn into the lungs. This risk, the aspiration, is high in patients with esophageal disorders, in neuromuscular diseases, or reduced consciousness. It can lead to aspiration pneumonia, a potentially fatal lung disease, while clinicians often use intestinal feeding to theoretically reduce this risk. Clinical studies actually have not found an increased incidence of pneumonia in patients receiving gastric feeding. Let's summarize these routes using the chart from this table. For nasogastric tube, which are short term, access under 4 weeks. The advantage are they don't require surgery and can be placed by a nurse or nutritionist or dietitian. They are the most common route for normal GI function, allow the intermittent feeding without a bump, and and less or are at least expensive, so low cost. While the disadvantage include nasal or throat irritation, the fact that disoriented patients can easily pull them out, a risk of tube migration, and the highest risk of aspiration in compromised patient. Moving further down the GI tract, nasodidinal. Nasodidinal and nasovaginal routes are also for short term use, less than 4 weeks. They allow feeding when gastric feeding are contraindicated due to obstruction or motility issues. Allow earlier feedings during critical illness and pose a lower aspiration risk. However, the disadvantage they are more difficult to insert and maintain, carry a risk of migrating back up into the stomach, and always require an infusion pump for administration. Now, for the long term enterostomy options like gastrostomy. Gastrostomy is for use lasting more than 4 weeks, is more comfortable than transnasal tube, hidden under clothing, allows the lower esophageal sphincters to remain closed, and allows for intermittent feeding without a bump. The downsides that is that it must be placed by a physician, may require general anesthesia, carries infection risk at the insertion site, and requires withholding feeding for 12 to 24 hours before and 48 to 72 hours after surgery. And finally, jejunostomy. Like gastrostomy, jejunostomy is for long term, more than 4 weeks use, and is hidden and comfortable. It allows feeding when gastric feeding is not possible, and allow for earlier tube feeding than gastrostomy after surgery, and carries the lowest risk of aspiration. However, it is the most difficult insertion procedure, requires an infusion pump, and is the most costly method. Now let's talk about the type or the kind of feeding tube. Feeding tubes are made from soft, flexible material like silicone. We select the tube based on the patient age and size, the feeding route, and how thick the formula is. We generally choose the smallest diameter uh, through which formula will flow without clogging. The outer diameter is measured in French unit. The French unit, like every one French unit equal 1/3 millimeter. So 12 French tube is equal 4 millimeter in diameter. The feeding tube. There is a double lumen tube are also available, allowing intestinal feeding and gastric decompression simultaneously. The enteral feeding. Once the tube is in place, what do we put through it? There are more than 100 enteral formula currently on the market available. Most of these can supply all of an individual's nutrient requirements if consumed in sufficient volume, which is an absolute necessity if the patient is tube fed for more than a few days. They can be used entirely on their own or alongside other foods. So we categorized most enteral formulas according to their macronutrient sources. So there's a standard formula, the most common category. Standard formula, also called polymeric formula, are given to individuals who can digest and absorb nutrient without difficulty. Sorry. They contain intact proteins extracted from milk or soybeans, known as protein isolates. Carbohydrate sources include hydrolyzed cornstarch, glucose polymers, and sugars. A subcategory here is blenderized formulas, which are literally produced from whole food like chicken, like vegetables, and fruit blended together. Elemental formulas. What is the patient digestive system is compromised? For patients with compromised digestive or absorptive functions, we prescribe elemental formulas, also known as hydrolyzed, chemically defined, or monomeric formulas. These formula or these formulas, the elemental formulas, contain protein and carbohydrate that have been partially or fully broken down into fragments that require very little digestion. They are also often low in fat, providing fat primarily from medium chain triglyceride or MCT, which do not require digestion and ease absorption. Specialized and modular formula. There are also highly specific formula for unique medical situation. The specialized formula or disease specific formula. These formula are designed for patients with illnesses like liver, like kidney or lung diseases, glucose intolerance also, or severe wounds. Note that they are generally expensive and their clinical effectiveness is sometimes controversial. Modular formula are created by combining individual macronutrient preparations called modules for patients requiring highly specific nutrient combinations. We can also add these modules to existing formulas to adjust their composition. Look at this table. This table summarizes the macronutrient sources we just discussed. As you can see, standard formula rely on intact protein like casein and wheat, complex carbs like corn syrup, solids, and vegetables oils, while elemental formulas use broken down components, hydrolyzed casein or crystalline amino acids, hydrolyzed cornstarch, and rely heavily on medium chain triglyceride oil to bypass normal fat digestion pathway. Beyond the source of the nutrient, we must look at the amounts. So formula characteristic the macronutrient, the protein, carbohydrate, and fat composition varies substantially. Most standard formulas provide 12 to 20% of the total kilocalorie for protein. This adjustable depending on the condition. For example, severe metabolic stress requires high protein, while chronic kidney diseases require strict protein restriction. Carbohydrate generally provide 30 to 60% of kilocalorie, and fat provide 15 to 30% in standardized or in standard formula. The energy density is another critical characteristics. The energy density of most formula ranges from 1 to 2 kilocalorie per milliliter. Formulas with lower energy density are appropriate for patients with average fluid requirements. Uh, formula with while on the other hand, formula with higher energy densities pack more calories into smaller volume of fluid. These are highly beneficial for patients who have or high nutrient needs but strict fluid restriction. Alternatively, patients with high fluids needs can use low density formula or simply be given extra water. Finally, we look at fiber and osmolality. Fiber containing formula help improve fecal bulk and blood glucose control, but we avoid them in acute intestinal conditions or pancreatitis. Osmolality refers to concentration of osmotically active solutes. Isotonic formulas have an osmolality similar to blood serum, about 300 millismoles per kilogram. Hypertonic formula have an osmolality greater than blood serum, while elemental and nutrient dense formula generally have higher osmolalities. But most people can tolerate both types without any difficulty. The factor influencing formula selection. With all these options, how would you choose the right formula? We select formulas after assessing several factors. First, is gastrointestinal function a functional but impaired gastrointestinal tract might require an elemental formulas. Next, or second, we adjust for specific nutrient and energy need, like carbohydrate control for diabetes or mineral restriction for kidney disease. We must ensure the formula meet high nutrient need within the volume of fluids a patient can tolerate. So we consider if fiber modification are needed and account for individual tolerances like food allergies. Ultimately, the chosen formula should meet all needs with the lowest risk of complication and lowest cost. This is the end of the part one of the enteral nutrition support. Thank you for your attention and see you in the next lecture for the part two for the enteral nutrition support. Goodbye.